Hello, everybody. It's Susan Clinton here with my co-host Erica Mello, and welcome to Tough to Treat. We have a couple of announcements before we hop into our podcast. Um, our March, our retreat, our Tough to Treat retreat is going to be on May the 1st. I think you all have heard us say this before on the podcast. We have the links up. If you are a member of our newsletter, you will be seeing, you probably have already seen our first email out about this. So come on in, join up. We have limited space. We're going to have a lot of really good information. We're going to be sharing some good stuff on recognizing drivers, secondary drivers, how to, kind of work with people who are a little off the charts with other types of influencers into their musculoskeletal health. We're going to have hot seats that people will be able to apply to, so you can get real-time conversations in the retreat about your tough to treat case. And Erica, anything you want to add?
No, I mean, we're going to have specific, exercise progressions and, why treating another region of the body makes sense versus just treating their pain generator or symptom, and how you would, effectively progress a patient like that. And it's going to be sort of jam packed with a lot of different things. But I think at the end, you'll really know how to assess from story to treatment what we call a complex patients from both of us. That is primarily the majority of our caseload. So I think that'll give you guys a great insight as to how to begin to assess and increase your confidence as well, I believe.
Yeah, absolutely. And I think part of the things that we hear from a lot of people are that they love, and their takeaways are not just the evaluation skills and not just like figuring out, what does this reset exercise look at? How do I load that reset exercise? But also the intervention part.
Yeah.
Which I think, everybody really wants a little bit more and some more variety on intervention. And we're going to be really talking about that and talking about that with all kinds of clients that we see.
Yeah, and the beauty of this is that it's highly interactive, and I've said it before, it's the podcast on steroids. So, but the steroids part is like you're going to get access to our brains versus just sitting and watching a PowerPoint presentation. And we'll do a bit of that as well, but it's going to be interactive. All topics are on the table, versus some of these other courses that people take virtually or more. You're just sitting and listening. This will be very interactive, and I think that's a great way to learn as well.
Mm-hmm. So also, this is podcast number 96. And we have 96 reviews on iTunes. And remember, we're on a quest for 100 by 100. Mm-hmm. So we've made 96 before we hit the 96 podcast. Let's get those next 4 in so we can have 100 before our 100th podcast.
Yes.
The reviews we are counting are on iTunes. We know there may be reviews on Spotify and Stitcher and some of the other places that we're so grateful to for housing our podcast for everybody. But it's the iTunes ones we're counting right now. So come on over to iTunes, look us up, find us, and leave that review. It would mean the world to us. We hope you enjoyed podcast number 96, and we look forward to seeing you in our May 1st retreat. Thank you. Hello, Erica.
Hello, Susan. How are you?
Yes, good. Podcast number 96. Let's get right to it.
Sounds good.
So this is this client is a young dancer. I thought about talking about her because there's a couple of things that I thought were quite interesting that everybody would be able to, get some good information out of. She is 16 years old, and her mother brought her to me. The ballet teacher said, they had tried a couple of other physical therapists for some chronic things that she had going on. And she just really felt like she wanted to try something different. So the ballet teacher who knows me really well, sent her over. And so they came into the door. Her main complaint, she's a very healthy 16-year-old. And her main complaint is that she has right hip groin pain that travels around the side of her pelvis to the back, and sometimes will travel down the side of her leg a little bit.
Okay.
So that's kind of her pain presentation: the lateral side of her thigh, posterior pelvic girdle, and the groin area on the right.
Okay.
So as she was telling me that, I said, we started asking questions, of course, like, how did it happen? What were you doing? And she told me that she said the best thing that she could think of the day that it happened was she was sliding on the floor in tap class, and her foot didn't slide. So she was like doing a lateral slide, and her, you kind of like, you anticipate that your foot's going to go, and your foot doesn't go, but your body goes.
Right. Oh gosh.
She said, and so it started bothering me then. And I said, did you stop? And she just started laughing. She goes, no. And I said, did it get worse? And she said, yes. And I said, what have you been doing since then? Well, I've been trying to keep going, but it's just not getting any better. And, now I'm starting to get a little bit worried about it.
I have this vision of her standing there with a leg like a stick in the mud and her flopping over the other side.
Exactly. So it's like such a kind of a sudden, abrupt thing to happen in a fast moving class. But she really didn't think anything about it. She wasn't worried about it too much, other than, it's now the pain is preventing her from doing a couple of things. And in dance, she said it's preventing her from taking her right leg and extending it. So extending her hip extension is hard. Developes to the side are hard, which is, extending your leg out in external rotation and abduction. For those who don't know the terms, those are the hardest ones. And then if she has to do any turning onto her right leg, so in ballet and tap, that means you would actually take your right leg and go out into external rotation a little bit, either straight lateral or a little bit extension, and then you would go up on that leg, to do the turn coming around. So when she had to plant her right leg for turning,
got it.
and
So
in the direction for a right turn, that's when it bothered her there too. And didn't really matter if she was doing bar, if she was doing center floor. And she said, of course, leaps with her leg behind her right leg being the trailing leg and not the front leg on leaps are the main thing. She goes, of course, it hurts when I go up and down stairs, and it's better, it seems to be better in the morning. Maybe by the time I walk around at school, it starts to get bad. I notice it walking. So it's getting more and more irritable is basically what's happening. And it's really preventing her from class. And as everybody knows, it's the springtime, and they didn't have a performance last year. Nobody wants to miss performance this year. So there is a bit of urgency on her end, because she wants to participate in the late
program.
late spring gala. Absolutely, 100%. And so as we were kind of talking about things, she goes, but I love teenagers. I've had the worst problems with shin splints for 2 years.
Oh boy.
It's like, oh, okay. And left greater than right.
Okay.
And she said that, and I said, so I said, what do you want to do first? And she said, let's work on the hip first. And I said, okay, but let's keep an eye on the fact that you've had the shin splints. She's calling them shin splints. She doesn't know what else to call them. She's rubbing the front of her thigh, of her shins, her tibia, down low to lower the lower half. And she says they hurt all the time, especially if I go on to point, if I am tapping, is terrible, and they get better, they get worse, they get better, they get worse. And I said, well, how are they right now? And she goes, they're slightly better right now.
So she does tap as well as ballet.
Does tap, ballet, and I forget what we used to call it, modern dance, contemporary. They call it contemporary now. Yeah. And so those are the 3 things that she does.
Okay.
And so anyway, so we just took a quick look at her shins. I said, point to me and show me where it's hurting. It's not on the lateral part of the shins, like where the posterior, or the inside where the posterior tib is. It's along the line where the anterior tib and the extensor hallucis longus tendons are. She just drew a line right down those tendons,
Mm.
just
Mm-hmm.
specific as can be. And I said, okay, so, let's, but her foot and ankle moved well. So I said, let's get up on your feet and see what's happening here. And I started off with having her just stand and rotate because I wanted to see, I'm thinking, as we're kind of going through this, I'm thinking feet, hip, back, thorax, kind of in there, like where's the stiff point here, because this is a fairly flexible, strong person. Is this just an overuse? What is this? Let's take a look at this and see. But I thought it was very interesting that both lower legs, but the left greater than the right was a problem, and it's the right hip that's a problem, or where her pain is presenting is around the right groin, posterior pelvis, and down the thigh.
Yep.
So, given that presentation, you could also be very clearly thinking L1, T12L1. You could also be thinking L5S1 pretty easily too.
Right.
So, just thinking neurologically as well, and, and how things happen, and the fact that, she, kind of like was going across the floor and the right foot didn't go. And so it made me think about the left foot and ankle, like what was going on there with this, like, did she not have the momentum to go across the floor? I just wish you could like go back in time and see a video of what happened to just kind of, be able to tease it out. So I thought, well, let's play with this first. Let's do some things that are easier that will give us good information. And then maybe we'll move into some sidestepping, kind of side sliding things as we kind of go forward. Go ahead.
Could she rotate, do like a body twist? Is that what you said?
So that's what we did first. And so we looked at it, and significantly not moving into pronation on the left as she twisted around to the right. A little bit better on the right, but not much better. Really hanging out kind of on the outsides of her feet.
So when she went to the right, her left foot didn't pronate, but her right foot was supinating.
Yeah.
Okay.
And then going the other way, her right foot pronated some.
Okay.
Okay. So there was a little more pronation on the right than the left.
Got it.
And hanging out more on the outside of that left foot.
Got it.
Which is kind of interesting, when you look at her.
Was she loading her left side more in standing, or was she pretty easy?
She actually was loading the right side just a little bit more.
Oh, interesting.
I also thought was interesting too.
Yeah.
So I had her bring her feet close together, and I thought, let's see what happens there. So when her feet were close together, both of her big toes kind of came up off the ground just a little bit. So she was really loading the lateral side of both feet, but she stayed pretty centered when we had her feet close together. When I asked her to bring her feet apart again, she loaded right, but stayed on the outside of the left foot a little bit, which I thought was a very interesting kind of thing. It's like, what is this? So we did a squat. And when she did a squat with her feet wide apart, that she could feel her symptoms in the hip area. It was recreated.
Wide apart.
Wide apart. I had her bring her feet back close together and squat down. No problem. We got onto hands and knees, did cat-cow. When she did the cow, it brought on the symptoms. When she rolled up into the cat, no problem. I had her do that with her, I had her do child's pose with her knees apart. Brought on the symptoms. When we brought her knees together, no symptoms.
No symptoms.
Really interesting.
Yep. And I'm also thinking, just because because she's pointing to that extensor hallucis, on the front of her shins. A lot of people who stand with those big toes up, possibly are over recruiting that, but I don't know if that's her or not, but that's just another thing that we're thinking about. But it's very interesting is that when she went wide, it was reproducing her symptoms more than when she went narrow. And when she went into lumbar flexion, right, it reproduced her symptoms more than a neutral or extended, right? Is that what I'm hearing?
It actually, no, when we were neutral and when we brought her feet together, she did better, which made her flex more.
So, right. So what about all fours again then?
Yeah, all fours. When she rounded her back up towards the ceiling, she felt better.
Oh, she felt better. Okay. I misunderstood. Child's
pose, knees together, she felt better. Child's pose, knees apart, she did not feel as good.
Okay.
So she didn't like abduction and external rotation. But when I checked her, she did have a little bit of difference. She didn't have the same amount of internal rotation on the right as she did on the left.
Mm-hmm.
Just I checked her in prone, and I wanted to see what it looked like with the hip straight, and extension and not inflection. And she definitely had less internal rotation on the right side. So she had and I don't know if it was structural or not. I'm just saying what she presented with. She
Mm-hmm.
can move her, into full internal and external rotation on the left. On the right, it was limited going into internal rotation in
In
prone.
in prone. That was
Yeah.
my next question. Okay.
Mhm. So I decided we stood back up again and I had her just do a bend over. And how did that feel? That's fine. Bend over.
Normal base of support.
Yeah. Feet wide, do a bend over. I don't know, maybe a little bit more. Feet together, do a bend over, everything's fine. And so I said, just for kicks and grins, put your hands on your hips and lean backwards for me. And, arch your back for me, like lean backwards. So she did. And she goes, that really bothers it. I said, okay. She could feel it in all parts. I said, all of it? She goes, yep, the front, the back, and the side. Very explicit. So I said, let's just try this. Because I knew flexion helped, but I wasn't convinced that was going to be the reset for her.
Mm-hmm.
So what I wanted to do, I wanted to just see what would happen if I got her out of compression.
Mm-hmm.
Because I felt like when she did extension and she did leg extension and she did leg external rotation and extension, she was always in this, compression position. When she did the cat part of cat cow, that brought her into less compression because she was on hands and knees, but still compression.
Mm-hmm. Right.
So I thought, let's just see what happens if we get you completely out of compression. I got her prone and I just had her do a cobra, a press up,
Mm-hmm.
which she could do beautifully. And I said, does this affect your symptoms at all? Nope, doesn't hurt a bit. Feels really good. So common for a hypermobile youngster.
Yep.
So I said, okay, do 10 of them. So she did 10 of them. And I said, right back up onto your feet. And we did some retesting. We tested squat. We tested hip extension, hip abduction, external rotation. All of it was getting better. Back down on the bed, 10 more. Back up again, and so by the time we did 3 sets of that, she didn't have any, she barely had any symptoms. So yeah, so I told her, I said, listen, I said, this is what you need to do. I want you to go to class, I want you to participate, but if this begins to come on, this is your reset exercise.
Mm-hmm. Right.
Not standing and leaning backwards. I want you down on the ground. And they have, they're used to me over there, so there's never a problem with the teachers if one kid goes over to the side to do a reset exercise and comes back.
Right.
She was very comfortable with it, and we talked a little bit about that it's just it's irritable, and we just need to settle it down, and this particular movement tends to settle it down, so let's go with that. If you move ahead down the road in the next 3 or 4 days and it's not settling it down, I want you to let me know. But otherwise, I'll see you in a week. Let's just get this thing to settle down.
Mm-hmm.
So that's where I left her on that. Do you have any questions on that or anything?
I'm still hung up on the wide base of support. Making her,
because it put her into more hip external rotation, I think, and less lumbar flexion.
Yes.
As she went down into the squat versus when she put her feet together, she had no choice but to flex her spine.
Right.
And bend, as we know, with the bend over or the squat with the knees close together.
Yeah.
So I think it was a flexion bias, but I think that the flexion bias was because loaded compression extension increased her symptoms.
Right. And when she was on all fours with the wider legs, that still also bothered her. Right. Yeah. So
until I took her into flexion.
Yes.
At her spine, and that made it a bit better. You could argue that was it the hip or was it the thing, but then it was the repeated lumbar extension that actually made her better. And by the end of the treatment session, she could do a full arabesque without any problem, and she was quite excited. So I was going to do the side to side shifting, and then I thought, you know what? We've got her to a place where she knows how to settle her symptoms down. Let's live to discover some things the next week.
Yeah.
So she went away, came back the next week, and I said, "So how is everything going?" She goes, "My hip is fine."
You
She
love
goes,
16-year-olds.
"My leg is very flared up."
What? The shin splints. Both
On
of
the
them
left. I
on the
said,
left. Of
"Both,
course.
most of the left." hmm
Yeah. Oh, yeah.
So here we go.
Yeah.
So this is the thing that you have talked about a number of times on our podcast, which is the back isn't the primary driver here. It was the secondary or the third, and maybe
Yeah.
there's still some thorax stuff in there, but not really. But the foot is the main thing here.
Yeah. You normalized her base of
This
support.
foot ankle piece here. Yeah.
Yeah. And she got back on her. You said she was loading on the right. You normalized her base of support.
Mhm.
Her nervous system's like, oh, I can get off my right leg now. Went back
Yeah.
onto the left or normalized, and then
Yep.
boom.
There it goes. Yep. And so boom. And it was, I will have to tell you, I have, I don't get to see a lot of very acute things. But except though it seems like this spring I've seen a lot of people have come in with really acute things, and that's okay. But anyway, I said, take your finger and draw it. It was right next to the shin bone, coming right down where you would expect the flexor hallucis brevis, the anterior tib in that region. You followed the tendon down to the big toe. It got much better as you went all the way down to the big toe on top. So just palpating alone told me it wasn't the extensor hallucis longus. Might have some involvement up high just because, there's not a lot of room.
Yeah. Yeah.
And, so I just started thinking, I thought, okay, we got to do some differentials here because I need to make sure 16 years old, tap, pounding, getting off of that leg and loading the right leg a little bit differently, having the leg get stuck. Are we dealing with a stress fracture here?
You took the words right.
Right, exactly, right?
Out of my mouth.
Thinking, okay, I have in my clinic a tuning fork and I have a stethoscope. So I thought, I said, let's just take a look at some things. So I put the stethoscope on and put it right on the tibia and I started tapping. And I moved it and put it in different places and tapped, looking for that muffled sound. And and then I had her listen, because she was like extremely interested in what I was doing.
Yeah.
And then I got the tuning fork and banged it, put it against her. And she said, although it bothers me because it feels funny, it doesn't hurt.
Yeah.
Okay. So and then we had a talk, her mom and I and her. And I said, you could go and have x-rays done, but probably nothing's going to show up. We're still too much in that acute window. So there's not going to be a bone callus. Let's watch this and see how it is, but let's see what we can do to settle this down, because she was just so sure. You could just see in her eyes. She goes, you're going to tell me I can't dance, aren't you? And I said, I didn't say that yet. I said, we were just trying to make sure that there wasn't something creepy going on. Right. So I said, now let's see how we can settle this down. So she was not going to be able to tolerate, I didn't think, any kind of standing pronation, out of pronation, down in pronation, out of pronation type of movements yet. It was that hot. So I took my hand and put it on either side of her tibia, and I started up high, and I just compressed in. And because dorsiflexion bothered her, and so did plantar flexion, of course, because it stretched it. Use that motion. And so I just came in and compressed the soft tissue in towards the tibia and had her do it. And we just kept going up and down until we found the area where if I compressed in, that felt good. So I taped her right there.
How did you tape her?
So I took the tape, and I wasn't worried about the lateral side of the tibia because there was no symptoms there. What I wanted to do was I wanted to balloon up the soft tissue on the inside of the tibia there. In other words, I wanted to try to take the pressure off of the insertion of those. Not so much the anterior tib, but the flexor muscle. The anterior tib was tender right at the point, but not up on the lateral side where you find the anterior tib muscle belly. It was more, it was more on the on that side down lower where you would expect to find the other. So when we did more medial compression and lifting of the tissue, that felt good. She could move her foot much better. So we just took the tape and went 3/4 of the way around. And then I took another piece of tape, kind of in a chevron kind of direction,
Mm-hmm.
lower. And then, so I start the tape up, then come down low, and then come back up again, and did 3 strips kind of like crossing each other like a chevron.
Right, like a kinesio taping, like a KT
Yeah,
tape.
yeah, like
Yeah,
Kate. Mhm.
got
And
it.
then I took smaller pieces and I went across the medial side, on the underneath, and then lifted and brought it up and over the top. So in other words, it looked like circumferential typing, but it wasn't, because it was alternated.
So were you going from inferior to superior
Yeah.
on all like the strips, and then sort of like almost like a V, but like at the top of the V, it's curved in? I'm just running for the
Yeah,
listeners.
exactly.
Yeah.
Mhm.
Okay, got it.
And then I took the top piece of tape and I went from underneath across covered the tibia over to the
Yeah,
other side with a lift of the soft tissue.
yeah, yeah.
So what I was trying to do was just help that soft tissue lift and give her some sensory input.
Yes, exactly.
And so we did it across the area that we felt the best. And then she got up on her feet and moved. And, and I said, where else do we need to put it? I love this building self-efficacy with these people, especially girls like this, because she kind of looked at me and I said, where else do you need it? And she said, I need some right here. And so I handed her the tape. I said, cut the corners off, do this, put it on. And
Oh,
so, taught her how to tape. And then I handed her the roll of tape and I said, your job is to do this every day. And let's just get the input in there to settle this down. You can go to class,
yeah.
but if it, she knew, I said, if it feels like it does right now, you're okay. If it feels worse, then you're not okay.
Yeah.
You have to take a break. You have to relax. You have to settle down and do this. And so, so that's where we started. But here's where we're headed. I did talk to her mother yesterday, and because I wanted to know if she needed to come in, if it was still like terrible. And she goes, the tape is helping. She's doing really well. We can wait till the end of the week. And I said, perfect, because I want her to be much less acute when she comes in.
Yes.
We're going to have to do some work now to really like on this foot mechanic and some things.
Yeah.
So
Yes.
we're going to be working in the lateral kinds of lunging, both directions. We're going to be working in how she moves from one foot to the other, the transitional loading on both sides. And we're going to be working on some of that with turning, because I want to see how all of that's working. Because I have a feeling what's happening is she's not getting her weight. This is in my brain. She's not getting her weight over her first metatarsal, her first metatarsal head. And if she's trying to turn that way, or she's trying to push off that way, she's overloading those tissues, on the top of her foot there. As they come in, she's overloading that area, and it's being put under undue stress with the repetitive stuff that she does.
Yeah.
But I want to help her I want to help her learn to get her weight over that first metatarsal head, because if she's going to be doing this the next couple of years, even, she's going to need to be able to load up on those metatarsal heads and even demi point or full point.
Right.
And
Yeah. I was going to ask, could she do a heel raise okay? Or did you check? I'm not sure if you checked that yet.
I did not check that yet, because she could, when she came in, I did do a real cursory quick neuro test.
Yeah.
She could go up on her toes and she could lift her and stand on her heels. And, and she did have sensation, and there wasn't anything to make me think neurological, but it hurt. Because the tissue was the soft tissue was so irritable that when she went up on her toes, just the stretching across the front, the stretching across the front of the ankle bothered her.
Yeah. I'm wondering, like, in people like her, I mean, she's so young, she hasn't had much time to develop really bad habits yet, but dancers kind of get into their routine, as you know, right?
Yeah.
And I'm wondering, if she's not getting that big toe down, she's probably really, significantly compressed on one side, her lateral, like her calcaneal cuboid, and I'll be nitpicky here with the biomechanics, but her calcaneal cuboid joint. And I just did this great course, as you know, this weekend with LJ Lee on the foot and the ankle. And it was just, you think about, like, we talked a lot about just the compression, the habits that people have, especially, in dancers, right?
Mhm.
I'm like almost chomping at the bit because she probably has something like that, or there's
Yeah.
something.
So the things to evaluate moving forward is how that foot copes with load transfer
Oh, yeah.
and weight shift, because there probably is. She denies any kind of severe ankle sprain,
Mhm.
but I'm not sure I quite believe that. Maybe she didn't have a major one, but she's had some minor ones, which can cause some changes in how we move. Because if the
Yeah.
peroneus longus and brevis are getting different input because of the joints, then that affects how that works. And they're probably being pulled in a lengthened position all the time because she's
Yeah.
on the side of her foot,
Yeah.
and her longus isn't working to bring that first ray down.
Yeah. Yeah.
So so I know everybody's thinking inside of the leg and, inside of the tibia and some of those types of things, but it's like it may be an imbalance more that could be have, some joint input, especially since, and it could be the fact that she's probably got, I didn't get into the weeds of her feet much because I'm just trying to settle this down first.
Yeah.
But I can tell you that her midfoot is stiff, and I bet you it's stiff on both sides. And that's
Oh,
a structural thing.
right. There's just rigidity in that. I mean,
Yeah,
the
and
dancers.
that's just a structural thing. People with, those a little bit more rigid mid feet look better in ballet
Yeah,
shoes. It just, it's just like
I
what it
know.
does. So here's the interesting thing, though, because me and the questions that I'm going to ask and some different things. Normal cycling with her period, because I wanted to know if this was like, do we have some, painful period thing going on here, or some, too much estrogen or something else, that could be affecting this, because these shin things have been going on off and on for 2 years,
Mm.
of which they got really bad last December, and then they got better again, and then, um, so I asked her about that. And then she is not a very tall young lady. She's 16, and she is probably barely 5 foot tall.
Oh, wow. No
And
growth spurt for her. Wow.
her mom is even a little bit shorter.
Oh,
She does not come from tall people, which
right.
is okay. But I asked her, I said, when did you stop growing?
Yeah.
And her mother said, oh, about 2 years ago.
Wow, that's early. Wow.
So at
Wow.
14, and I said, when did you start your period? At 13. So it's not that out of bounds, but the thing is, she had her last long bone growth spurt was about the time that this started coming on.
Right. Yep. Yep.
So
Also,
I'm just wondering if she had, she wasn't gonna, it doesn't really matter if they grow to be 6 foot taller, they grow to be 5 foot tall. There was
spurt.
her mom said she was like little bitty
She grew
until
for
she had
her.
her adolescent growth spurt, and then she grew up, several inches taller than her mom, which makes sense. There's usually average out between their parents somewhere. I asked how tall her dad was, and she said he's about 5'5". They're just not big people, like tall people, which is
Yes.
fine. But I was just interested in the fact, and we kind of talked about it. I said, I don't know how much that had to do with it. Maybe that's what kind of set this up a little bit. Maybe the repetitive stuff she was doing around the time of the long bone growth happened. It's interesting that it's on both sides.
Yes.
And the kind of tissue that needs to lengthen across the tibia there. But very flexible hamstrings, very, she's, flexible, and some, not terribly hypermobile, but somewhat hypermobile. But it's where she's not is I think her feet and ankle.
Yeah.
Sometimes you'll see hypermobile girls will have, hamstrings over recruiting, because that's where they can gain some stability, some stiffness in the thorax and the CT junction for sure, to make up for where they're moving a lot. And for her, I think it's foot ankle.
And how long has she been dancing? I forgot to
She's been
ask.
dancing since she was like 5 or 6 years old.
Oh, so this is long.
Yeah. This isn't anything new.
Right. So that makes sense, the growth spurt, because she's been dancing. You can't like chalk it up to just a recent issue or an overuse. She's been overusing for years.
Yeah.
Yeah. And it's so interesting though, especially with athletes and dancers, because, people say, oh, they're hypermobile, and a lot of them are. However, their strategy, their strategies are, one of sort of muscular over recruitment, or
Mhm.
because they can cheat really well. They can compensate and they can go down different, use different movement patterns. But a lot of time you end up, telling, even though you may see somebody's foot that they're sort of pronated or they're rigid, there's going to be parts of the foot that are going to be just the opposite. So, that you may have a rigid midfoot arch, but have, some, loss of control in the forefoot, or, et cetera, et cetera. And so, yeah, I think sometimes if we make those statements, oh, they're pronated or supinated, that sometimes, I like the word rigid, like you use, like a rigid foot. And a lot of times you end up releasing, even though they are hypermobile, you end up having to do like whatever kind of release or movement, whatever to actually engage different muscles. But I think it's important that, especially for people who treat the dancers, it's not all about, yes, we need to give them a ton of movement and heel raises, but no, you need to really assess specifically their movement pattern. And it may, especially
Yeah.
with feet, there's how many bones are there in the feet? I mean, there's tons.
Yeah.
You need to really, especially dancers, they need you to feel your hands on their feet, because it's so much in their brain, right?
Mhm.
Imagine how the part of their brain that devoted to the foot. Imagine how large it is on a dancer, like with hands on a pianist. They're so lit up there, and it's important that you. I mean, I know you do, we all do, but it's important that we don't like make blanket statements. I'm not sure why I'm going off on this tangent, but it's just it's important.
Yeah. It's important to look at all the different movements and
Yes.
really help her, I think it's significant that it's going across a diagonal.
Mm-hmm. Mm-hmm.
I think it's significant how when she was loading up the right hip and some of the other stuff, what was happening, and the hip got better, and she started, because when she was standing wide, she was back over, on both feet. Although she didn't like standing wide on both of her lower legs.
Yes.
And you can
Yeah.
imagine why, because the weight is out on she
Yeah.
doesn't pronate in,
Yeah.
or she doesn't drop down. She just
Yeah.
stays further out on the outside
Fan.
of her
Fan.
feet.
Yeah.
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 So the name of the game was settle it down and give her the ability to take care of herself.
Yeah. Yeah.
With the reset exercise, which was good. I told her, I said, if your hip bothers you, just, the reset exercise, just go for it. But I said, let's just get this to settle down, do the things that feel good. And, she's going to be back, and we'll spend some time working on, what does her foot look like, and all of these different positions and things she needs to do. Um,
Yeah.
because this is the time, her body is changing, at 16, 17, 18, our bodies start changing. And this is the time to pull, to get some nimbleness in her movement system. Uh,
Mm-hmm.
so she doesn't have to quit dance because she doesn't have great shock attenuation or over recruitment or whatever the thing may be that's going on there.
Yeah, and it'll be interesting too to see when because training, like, because you gave her some great self-management, with the taping, and I don't use kinesio tape very much anymore, but I like more because I just don't have it, but I can get it. I like that. But to training the lateral movement, like I'm more of, it's great, and also doing it in front of the mirror, because they're all in front of mirrors, right? Seeing if she can do like a split squat with the fanning with the back leg, and deep squatting, and almost like you would do for a hip almost, right? These are similar exercises,
Right.
but more of an emphasis at the foot.
Yeah. And where we'll capture that is in her, first, second, third, fourth, fifth position plies.
Yes.
Because second position is feet apart, fifth position is the ultimate together. Fourth, puts you in a wide, we're going to really review those, because I want to see what happens with her feet, if her foot's in back for fourth or foot in front for fourth,
Mm-hmm.
how she handles that and copes with that.
Yeah.
And what we can make, what changes we can make. I'm still not convinced that there may be a little bit of something in the thorax, the mid thorax area, that I
Yeah.
think may, if she doesn't, I'll have to see when she does her movements,
Yeah.
she kind of locks in there.
Yeah.
And if getting her to kind of just ease out of that, they kind of tend to lock into extension in that mid thorax,
Mm-hmm. Mm-hmm.
and see if we can get it. If that's the case, then, help her get out of that a little bit, and see if that begins to free her up to move over her feet differently. I
Yeah.
don't know yet. So, but I definitely think that there's going to have to be a little bit of something through the thorax as well as the feet in order to get get everything moving through the body in a good way.
Yeah,
Mhm.
because if the foot can't adapt to the yeah, because if the foot can't adapt to the new center of mass, because you got her the right hip good, and she's trying to if the foot can't adapt because of some dysfunction, the thorax is a great area to laterally translate and adapt and take the load off the foot. So I
Yeah.
wouldn't be surprised as well.
Yeah.
So sounds like fun.
Yep.
I love treating young kids. I think they're plus there's they don't have a lot of bad habits yet, and they heal quickly. Well,
Yep.
awesome. Well, thank you, Susan,
Okay.
for sharing.
Absolutely.
Awesome. Well, everybody, thank you once again. Podcast number 96, and we hope to see you on our retreat on May 1st. And thank you again. Bye.
Bye.